suppose, what advice do you have for our patient community? Because I feel the patients can live well now because of the great news and targeted therapies, but it's maybe healthcare providers, not you guys, you fully understand what our CLL community are going through, but it's trying to access them different pre-exposure prophylactic treatments. Sorry if I'm getting it all mixed up, but you know what I'm talking about. The antibodies, the COVID antibody treatments, all these things, where do they come into play now?
So it's really uplifting to hear some positive stories from the audience here. And everyone who has CLL is so marked by it, in those early days particularly, that it lives with you. I know that from my experiences in the clinic, and there is nothing so isolating as a serious diagnosis. I'm pleased to hear the positivity around it, but let's be clear, nobody is lucky to have CLL. And it comes with a huge baggage of problems. And the major problem, I believe, is infection. CLL in many ways is an immunological disorder masquerading as a cancer, or a cancer disorder masquerading as an immune deficiency, but either way, the two things go hand in hand. It causes severe problems with the T cells, those cells that are meant to be going around the body coordinating the response to infection. It causes problems with the normal B cells, so that in virtually everybody who has CLL over a period of time, the immune system will slow down. Antibody levels will drop as time goes by. It's called hypogammaglobulinemia. I don't know whether you're aware of this, but it's so important to be aware of it. And it means that attention to infection, early intervention with infection, and prevention of infection is one of the major parts of looking after yourselves as part of that contract that we have as clinician and patient. I'm going to give you this horrible diagnosis and you're going to do your utmost to stay fit and well. But part of that active bit, which is in many ways such an important part of taking control of lives, of your own lives with CLL, is to engage with that risk of infection. And that means being fit, being active, eating well, all those things, and then the whole business of engaging with vaccine programs. So we found during COVID times that COVID in particular wreaked absolute havoc with our patients and caused untold sadness and misery. The world did change with vaccination. The more COVID vaccines that our patients with CLL had, the more effective they became and the better protected people were. We've managed to move on quite a lot. Most people with CLL will have had multiple vaccines. There are a few that choose not to do it. There are other vaccines as well, so we usually recommend, please have pneumonia vaccines. Make sure that you have the seasonal flu vaccines. Don't forget the kids have the sniffy up the nose flu vaccine when the time comes. And that's a live vaccine. So if there are kids, grandkids, or friends of grandkids knocking around who have had the intranasal flu vaccine, don't forget that's a live vaccine. You could catch flu from those kids. So being aware of that and keeping people at arm's length for maybe 7 days is probably a reasonable thing to do. Keeping up with the seasonal flu vaccines is eminently sensible. Having the COVID vaccines as and when they are available for you is eminently sensible. And having half an eye on the longer term protective effects of things like pneumonia vaccines is helpful. Now, there's an issue with pneumonia vaccines because on the face of it, it's great. I have a vaccine. My immune system's still good because I would recommend it at the very early stages when you first come to me with the diagnosis. I'll say, go off and have these vaccines and GP will sort it out. So we do it as an early thing. But how much of that is because it will have a protective effect and how much of it is actually documentation that you've had the vaccine, but still run into problems with infections. It's part of an algorithm, within the UK at least, an algorithm for access to immunoglobulin replacement treatment. So half or more of what I'm thinking is, if you have a vaccine, a pneumonia vaccine, and it's documented, and you're still getting infections, and you're on prophylactic antibiotics if you do run into problems with recurrent infections, then the gatekeepers, because it's not us, we're not the gatekeepers generally of immunoglobulin replacement. Those gatekeepers within the UK context will approve the use of immunoglobulin. But that requires that people will have already jumped through a number of hoops. So you might think that, oh, I'll have the pneumonia vaccine, it's going to help me. It may or may not help you, but it is something that needs to be done at an early stage so that you can, in future, access things like immunoglobulin treatment. And that's a really important point that I don't think people recognize. And your GP is a massive part of your care. Massive part of your care. Maintaining good contact and relationships with your GP is so important. If you need antibiotics for infection, please keep a record of this. It's so helpful in clinic. If you can say, I had 4 courses of antibiotics this year, I had this in January, this in March, this in April, and my sinuses are still causing me trouble, then we are halfway to understanding the burden of infection. The problem with CLL is that people will die of infections. It's a serious problem, and it cannot be ignored. Okay, so it's such a big thing. I don't know if anyone wants to. Sorry, that's a bit of a downer on that one, but you know, there's an important message in there.
From a patient perspective, with regard to infection control or prevention and control, and having been plagued with infections throughout my whole CLL life, it's been, once the CLL was being treated and my immune system was subdued, I was more susceptible to infection. It's just a fact of life, and it's a fact of life I've had to get to grips with. And once my CLL is under control, then the quality of life that I choose to live and the life choices I make in respect to my movement within the community, whether I choose to fly or not, whether I choose to go to the theatre, and things like that, are decisions that I take on a kind of a personal risk assessment basis. And I'm looking at all aspects of it. And yes, I backed out of some events because, no, I'm not comfortable. But equally, I flew here from Edinburgh. I was the only person on the flight wearing a mask. Now, does that single me out? It probably does these days. Does it bother me? No, it doesn't. I'm old enough and thick-skinned enough to have that type of thing wash over me. But it's a conscious decision, and I feel I'm doing something about it. I'm trusted by virtue of the relationship I have with my clinical team to have a rescue pack of antibiotics. And if I feel an infection coming on that it's more than the normal type of stuff, and you've probably seen me using tissues a bit today, that's just ACE and stuff like that just does that. And so if I need it, I take it, but I let the CNS know I've just started this so that it's on record that I have yet another infection. Whether that infection is significant or not remains to be seen. I've had 2 different FES procedures. FES is frontal endoscopic sinus surgery. I had a postnasal drip, which basically meant that I was getting a lot of upper respiratory infections. And long-term antibiotics didn't do anything for it, so I had sinus surgery. That gave me the biggest sort of remission. We're talking about remission from the CLL drugs. I was getting remission from infections. And you really do become your own best advocate in terms of being able to manage that. And as Ben said, keeping an account, keeping a journal of your infections and being able to objectively say to the clinical team, look, this is regular. Well, how regular? These are the facts. The treatment choices the clinical team propose to us when we're in the shared decision-making process are based on evidence. So the feedback that we give our clinical team, if we have that record in our journal to be able to say, well, I've had 3 or 4 infections, or whatever the actual number is, and how severe they were, how limiting, then the best decision can be made with regard to how serious this is. And it's a delicate balance between prevention and control. And over time, over the winter, over the summer, those reference points can change. But what I find is it really improves my quality of life if I have an awareness, I have the ability to do something about it. I don't have to ask permission of my GP to give them a sputum sample pot to do an analysis on. That's, yeah, okay, he's put one in. Whether they get qualitative information from that, I know that, you know, it's not always definitive, but it's an indicator. And developing, as Ben said, developing that relationship with your health centre or your GP, whatever jurisdiction you're in, is vital to be able to do something. And it also gives me the satisfaction of actually doing something and being in control. One of the things during my diagnosis I really rebelled against was lack of control. This gives me some control. I have some level of management, and I feel that that's a practical step I can make.
Is there a rate at which our CLL is, or our CLL compromises our immunity? But I'm also then wondering, you know, kind of because I'm now on the venetoclax treatment, you know, kind of, which is, you know, kind of a time-bound treatment. At the end of that treatment, when I'm finished, will I still be immunocompromised, or will I have a period where actually my immunity is back to normal?
And I think it's a really good question, and there's so much to maybe unpick from that. So you reflected on your presentation this morning, and obviously you were very unwell at diagnosis, and that was because you had a big burden of CLL. And Ben nicely described how when CLL is active, our good, healthy B and T cells are probably just not functioning the way they should. So the fact that you had such active disease was probably contributing to why you had so many infections, but actually bringing the disease under control has maybe allowed a degree of reset, so therefore your immunity has improved somewhat, but it is still compromised relative to someone who doesn't have your history. So, but that's your sort of unique set of circumstances, and it may differ to others in the room. Perhaps if you're living with CLL but a lower burden of the disease and on active surveillance, yes, you're still somewhat immunocompromised, but not to the same extent that you were at diagnosis. And I think once you complete your therapy, the hope is the further you get away from therapy, and if you are still in a deep response, hopefully that will be a good period for your immune system. But again, these questions are very hard to answer, and we can be equipped by looking at things like your total white cell count, your lymphocyte count. There's further in-depth work we can do with lymphocytes, and then your immunoglobulin levels, all to give us a bit of a steer about how effective your immune system is. But sometimes it is back to that sort of pattern of how you have behaved. How many infections are you getting? Are they in the same space, like a sinus space, because of an anatomical issue? So there's so many different factors that feed into this. And again, it's that back to that sort of theme through the afternoon, that we need to individualise how we do things with you relative to other people. And I really like what was mentioned there about a risk assessment almost, and I've sort of almost had those conversations and even used that term with some patients over the years. It really depends where you're at in your journey with your CLL, your treatment. your infection complications thus far, and then as you embark on doing things, whether they be flights or holidays, I think it depends on where you're at in that process and how important a certain event is to you. And it is almost like risk assessing certain things and certain events in order to try and keep yourself as safe as you possibly can. And a lot of the strategies that we've mentioned there, prophylactic, antivirals, antibiotics, the role of IVIG if it is clinically indicated, all of those things are just there to try and keep you as healthy as you can.
I was 10 years on IVIG, so every month I was going into hospital and surrendering my veins to the system, and I was very grateful for it, because without it I'm ill a lot. And I know there are jurisdictional issues for us here, because we're dealing with the Republic of Ireland and the UK. Certainly in the Republic of Ireland, I was not even aware that there was an alternative to that IVIG system until I found a patient in Cork, an old man, who told me he was doing his own IG. And I really had to push. I'm based in Dublin, a very, central centre. And at the time, my haematologist said, you don't want to do that. You don't want to faff around with that, because then we won't have you in the hospital and we won't be checking your bloods every month. And I really pushed. I said, because this, for me, so we're back into that patient preference space. For me, I would rather do these weekly infusions, and they're not easy and they are a bit faffy and they involve putting needles into your abdomen. But now I feel like I've mastered it. And as soon as I'm hooked up, I put my shoulder bag on. I can sit at my laptop. In theory, if I wanted to hoover, I hope I don't ever have to do that. But I could do it. It could be done. So that was my preference. But yes, I do it every week. But I just think it's important for people in the room to know that once it has been clinically indicated, and I think about a third of us eventually will require this replacement therapy. There are options even within, and depending on the jurisdiction you're in, and I know that there are kind of more hoops to jump through maybe in the UK system, but just important for people to know. And I think, could you answer the question about how frequently people's immunoglobulins should be checked for that? Because it seems to be a progressive situation where they're getting more and more infections, and oftentimes we find patients ask about your immunoglobulins, do you know when they were checked? And they don't know.
Certainly, if I do see a patient have more than a couple of infections in a short space of time, we will check immunoglobulin levels. And currently in our practice, the IgG level has to be below 4 and 3 infections in a fixed amount of time, usually 6 to 12 months, before I am allowed to prescribe IVIG. But certainly if you meet those indications, that is something that we will give. The majority of our practice is still intravenous. We do have a smaller number of people who are on subcut IVIG and in the community. We are trying to move towards that if we can, but capacity is an issue for us. So we are scrutinised in terms of funding for this, so you have to meet certain criteria for it to be indicated. But certainly I would agree, anyone who's having recurrent infections and an IgG less than 4 in our practice will usually go on to IVIG, definitely, yeah.
The very, very interesting problem that you've had of improving immunity from the sort of what we just call phenotype, which is the outward manifestation, so reduction in infections on treatment, just showing how multifactorial it is. In terms of immunoglobulins, this affects pretty much everybody, but it takes a variable period of time, usually a number of years for it to reduce. So it's not something that will be entirely predictable, but for most people it will gradually drop. Normal is sort of 6 to 16 grams, so it could take a long time for it to fall if the baseline is in double digits. I would check it at diagnosis, and I think that's part of the educational process that I would like to go through with my patient. If I could diverge away from the blood counts, because I think that there is a risk that we can become obsessed with a white blood cell count, and actually start looking at some of the other things, and immunoglobulin levels is one of those. So being aware of what the immunoglobulin level is very helpful, I think very salient in CLL. probably checking it every 6 to 12 months, more frequently than that. And if it's normal, checking it on an annual basis is probably more than enough. If you have the pneumococcal vaccines, then it would be sensible to check the specific immunoglobulins afterwards to see what kind of dynamic response there is. And that can tell a little bit about the way the immune system is working. So if you have a pneumonia vaccine and then 2 months later you have a blood test, at least 2 or 3 months later you have a blood test, then that can give some indication of whether the antibodies, the specific antibodies, have improved. And that can, paint a picture, and that's helpful.
It's a question about vitamin D, actually. So geographically, because of where we all live, from April Fool's Day to Halloween, between 12 and 2 is the only time you can absorb vitamin D. And if you're a CLL patient and you're wearing factor 50, how much vitamin D should you be taking?
I suppose sometimes when patients are very tired, we will check their vitamin D levels, and nearly everybody we check are subtherapeutic, not necessarily low enough that they need full prescription, 20,000 units, weekly to build it back up. But nearly all of our patients, we would suggest just over-the-counter vitamin D to build it up, and I think most of us take vitamin D when we remember as well.
And is there a certain international unit level that you recommend medically?
I think it's just the 800 international units, which is
Thank
just
you
a
so much.
standard over-the-counter dose.
Another little small thing just adding to that, and I'd kind of forgotten it when we were talking about fatigue earlier on, was ferritin levels and iron levels. I know that sometimes that helps patients, so I don't know, but we don't really have time for a big discussion on it, but I just thought,
I think, Michael, certainly we'll always look for reversible causes of the fatigue and other reasons maybe for anemia, so we will routinely check things like iron, B12, folate, vitamin D, etc. We'll look to see if there's anything we can do to try and help, but a lot of the time, sometimes those parameters are actually okay, and it is maybe perhaps the CLL that's the cause.
So taking an iron supplement, vitamin D, these things can be one way of taking control of a healthy diet. Very unlikely to cause problems, but having that conversation with the team about is there a specific deficiency, as you point out. If there is an iron deficiency, then that may require separate investigation, for example, and just being aware that there are also other ways of being in control. The boring stuff about being healthy, attention to diet and exercise, and a prompt attention to infections. Those are also other ways of taking control and being in control of our lives, which is something that none of us ever are. We just fool ourselves, don't we?
I was going to say earlier on when you were talking, I was going to tell everyone in the room that there's an exam at 4:30, that time before you get out the door. But actually, it kind of leads on to something of patient advocacy. And when you get to know the advocates all around the world, the CLL Society, Brian Kaufman, has smart patients get smart care. I don't particularly like that. It's like saying the patient has to go and get a PhD. But informed patients, I know Patrick Thornton was doing an interview one time, and he says informed patients have better outcomes. I thought I liked that one better,
And I think also what Brian said early on is get to know your team, because there is a relationship to be built up, and there is mutual respect and regard to be found and discovered in those relationships, which are mutually rewarding in themselves. And understanding the way that your clinicians think, nurses and doctors, how we think about things, gives an insight into how we might respond to changes as they arise, but also in the way that we might look at parameters, blood tests, clinical examinations, etc. But also the corollary is that we then also have a much clearer idea about what's important for you, about how, where is your risk barometer set in terms of what would be acceptable, and what are the priorities in your lives, the important events that might be coming up. So there's definitely a two-way street, and it's a genuine thing. And that element that you can't measure, that kindness that flows between us, is something that grows out of that relationship.
And I'm going to get in trouble for letting this run over. And I suppose the final thing is to can you briefly just summarise the day?
I just want to say one more thing from Ben. There are no dumb questions. That was one of the first things that I was told. There are no dumb questions. Ask whatever questions you feel you need answered. And just a very impressive team here, apart from me. Thank you for all the information you've imparted. If I had to have... I don't have CLL, fortunately, but if I did have CLL and I needed a team, they're here.
I've just really enjoyed today. I've really enjoyed the conversations today. And I also think that, there's been loads of new treatments, lots of progress in this field, and that's continuing. There's lots of research going on, lots of research in the blood cancer sector in terms of the number of assessments going through NICE. There are other novel and individualised treatments which are not yet available for CLL and maybe in the future. So who knows what we'll be talking about in terms of treatments and new treatments in a couple of years' time. So I think that is another exciting and hopeful thing for the future.
I suppose as a nurse, I'm always learning. I suppose we're all always learning. But most of the advice I gave you is stuff that's come back to me from patients over the years, and that's what's built up. So everything you guys come and tell us, we're able to feed back. So it very much is a two-way process. We do not have CLL. We treat people with CLL, so we don't always know what works from a psychological perspective, emotional perspective. So you come to us and telling us your issues and how we can help. It is very much a two-way process. So, yeah.
I suppose I'm just really inspired to see so many of you here today. I've really enjoyed all the discussions so far. I look after patients with CLL, but other disorders as well. It is a real privilege to look after patients with CLL, and I find it very fulfilling because it is often a very long journey, and you get to know many of your patients and their families really well. And I think probably what we try to reflect on today is just how much things have changed even just in the last decade. And the theme of today is breaking down barriers and building hope. And I come away from today being very hopeful, just seeing the rate of change in the last 10 years and what is probably ahead of us all. So it's been a real pleasure to be here today.